Good morning, good afternoon, good evening, colleagues. Welcome to this session of the South-South Learning Network and the Global HIV Prevention Coalition, together with our colleagues from INPUT, International Network of People Who Use Drugs, and of course, UNODC. My name is Fariwa Sultani. I'm the Chief of the HIV/AIDS Program and Global Coordinator for HIV with UNODC based in Vienna, and I welcome you to this webinar. This webinar is the 11th webinar on the key population community of practice organized by the South-South Learning Network and the Global HIV Prevention Coalition. So welcome to the webinar. And we will be discussing addressing risks of stimulant drug use among people who inject drugs. And this has been, there's a series of topics that have been identified by the community of practice, and this is one of them, because stimulant drugs are widely used around the world for various purposes, such as producing feelings of euphoria, increasing confidence, sociability, energy, wakefulness, and as well as reducing hunger. And as per our World Drug Report, the supply and use of cocaine and amphetamines, who are amongst these group of the stimulant drugs, has faced a six-fold higher risk of mortality and has been on the rise in the world. There are also increased risks of suicide, psychosis, depression, and violence. And to address these risks, it is crucial to implement evidence-based and comprehensive harm reduction approaches tailored to the individuals who use stimulants. And there is more substantial research investment needed to develop more effective, innovative, and impactful prevention and treatment programs for this population. So the treatment is still, not very advanced. So we really need to work on that, but we are also working on that. So the objectives of this session, we have a lineup of very excellent speakers in this session, but the objective is to raise visibility, awareness, and a holistic understanding of the extent and the risks of stimulant drug use in relation to HIV and other health outcomes, to share with you the global guidance and recommended best practices for addressing stimulant drug use, to understand the practical evidence-based harm reduction approaches for addressing stimulant drug use in various programming scenarios with people who inject drugs, and to identify additional collective actions needed at the global or regional level to support the response. So while the stimulant drugs affect various members of the key population, in this webinar, we will specifically focus on individuals who inject and use drugs, although this is a problem of intersecting, nature for people of different key populations. So without further ado, I would like to give the floor to the first speaker, who is my colleague, Dr. Monica Chupagia, who is a part of our team. And she will talk about a global review of the prevalence, harms, and interventions related to stimulant drug use, with a particular focus on people who inject drugs. Just to mention that Monica has many years of experience working in the field of harm reduction. I won't mention the number of years, but she has a long working experience on harm reduction, and actually working for more than 5 years on the stimulant drug use. So because this is an emerging situation in many countries. And so before joining UNODC, she was working with the International Harm Reduction Development Program for open society, also focusing on HIV, injecting drug use, and human rights. So please, Monica, you have the floor. Thank you.
Thank you very much, Fariba, and thank you for the kind introductions. Could we have my slides up? There they are. Okay, so what I will talk today is about the UNODC work in addressing HIV and hepatitis with and for people who use stimulant drugs. And can we move to the next slide? So, UNODC has the mandate, is the lead agency on addressing HIV and hepatitis and other bloodborne transmitted diseases among people who use drugs and people in prison. We are, in our work, we are implementing in synergy UNODC strategy and international agreements like the outcome document of the UN General Assembly on drugs, a special session on drugs, as well as the Global AIDS strategy and the political declaration on HIV/AIDS, and yet another Global General Assembly resolution. Let's move to the next slide. Just wanted to mention in our presentation that actually this year we are proudly celebrating 25 years since we are one of the co-sponsors of the UNAIDS. We joined in 1999, in particular to address the HIV epidemic among people who inject drugs. But since then, we developed our work very much. And we also celebrate 20 years since UNODC is working to provide support to the prison population, also in addressing HIV and other bloodborne transmitted viruses. Next slide, please. So I know that Antons has some data, so I didn't want to repeat the data, but I wanted you to see the extent of the use of stimulant drugs in the world. And you can see here in various colors, this is the latest data from UNODC World Drug Report. So with very few exceptions where probably we don't have yet enough data, the use of stimulant drugs, methamphetamines, amphetamines, or other amphetamine type stimulants, cocaine, synthetic cations, and other new psychoactive substances, as well as pharmaceutical products are very widely spread around the world. In the next slide. In our work, we focus on the health risks related to stimulant drug use, as Fariba mentioned, and we have, the transmission of HIV and hepatitis B and C through the injecting route of transmission, increasing the risk of bloodborne viruses, and it's much higher, the risk comparing to the heroin injecting, because of the higher frequency of injection, the more frequent sharing, the reusing of needle and syringes, and also the sharing of other paraphernalia like filters, mixer, and containers. And there is also the sexual route of transmission that might be particularly elevated among men who have sex with men, and bisexual men related to chemsex. And we are also looking not only at the bloodborne viruses, but we are also looking at acute case of intoxications, which are very much different and have less means of reverting as the heroin overdose. And this acute case of intoxication are present particularly challenges for first responders and the emergency health services, because it's a challenge to identify them and relate them to one of the substances. No, next slide, please. So again, some data from UNODC World Drug Report. 13.9 million people are injecting drugs globally. This is, of course, an estimation, and it's hard to separate here how many people are injecting stimulants and how many people are injecting opioids. In the next slide. We know that, again, it's an estimation, then 1.6 million people who inject drugs are living with HIV, which is 1 in 8. And the next slide. And 6.8 million people who inject drugs are living with hepatitis C, which is more than half of the people who are injecting. Next slide. From the recent data that we have from the Global State of Harm Reduction, recently published less than, I think, 2 weeks ago, we know that 93 countries in the world are implementing needle and syringe programs. It's true, the majority of them are not implementing these services at the level that is needed and the coverage needed to have an impact. But still, we have 93 countries in the world in 2004 who are implementing needle and syringe programs. Next. In prison, the situation is not that good. Only 11 countries are implementing needle and syringe programs. And the next. For people who are smoking, the safer smoking kits that we are recommending very much are only available in 25 countries, sorry. And the next. Well, here you need to click because these are a couple of times, because there are a lot of barriers for people who use stimulant drugs to access harm reduction services. I think you need to click more. Yes, and one more. No, back. Okay, so you can see here that there are a lot of barriers, and this list is not covering all of them. But criminalization of people who use drugs, criminalization of drug use, possession, and consumption, stigma and discrimination, as well as limited financial resources, lack of policies that can effectively increase access to harm reduction services for people who use stimulants are some that worth mentioning. Also, law enforcement practices are an important barrier in many countries, and the high rates of incarcerations resulting from this. Now we can move to the next slide. So as Fariba mentioned earlier, more than 5 years ago, we started to think about providing technical guidance for countries who would like to scale up HIV prevention, treatment and care and support, and hepatitis equally for people who use stimulant drugs. We did this jointly with our colleagues from WHO and UNAIDS. What is unique for this publication is that the core of this guidance was developed by our colleagues from the civil society group, and this is the experience of people with who have lived experience that is distillated in this paper. This paper recommends a set of 8 interventions, similar with the harm reduction package, but adapted to the people who use stimulants. Of course, the first one is condoms, lubricants, and safer sex programs. Then for people who inject is needle and syringe programs, but also other commodities. HIV testing services, antiretroviral therapy, and we are discussing the interaction between the antiretroviral medication and various stimulant drugs substances. Evidence-based psychosocial intervention and drug dependence treatment. Even if the paper is done more than 5 years ago, we still mention the early steps that were taken in the pharmaceutical pharmacotherapy of amphetamine and methamphetamine type drug use disorders. Since then, they developed, when we were describing this, it was just in 2 countries. Now more countries are starting to implement pilot project on this. Another intervention is prevention, diagnosis, and treatment of sexual transmitted diseases, hepatitis, and tuberculosis. The targeted information and education, and the last but not least, the prevention and management of acute intoxication, explaining very clearly the difference between the heroin and opioids acute intoxication and the one with stimulant drugs. Next. Based on this technical guide, we developed a capacity building program. It's divided in 3 modules, one on amphetamine and methamphetamine, one on crack cocaine and pasta coca, and one on new psychoactive substances. Because, you know, there are differences between the interventions that can be implemented. And so far we developed we implemented this training in face-to-face trainings and hybrid and virtual in many of UNODC high priority countries, and not only. The request for these trainings is increasing more and more as the use of stimulants is increasing all over the world. In the next slide. So as I said, we are focusing on these 3 types of substances: cocaine and smoke cocaine, methamphetamine and amphetamines, and new psychoactive substances, because there is evidence that the use of these substances can be linked with HIV and hepatitis transmission. As we saw in the first, in the slide with the big map, there are many other stimulant types of drugs, but we are focusing in our guidance on these 3 who are linked with the transmission of HIV and hepatitis. In the next slide. As I said, the first intervention that is recommended is condom, lubricants, and safer sex programs, and we're focusing also on chemsex and HIV prevention. And we recommend here 4 interventions: pre-exposure prophylaxis, post-exposure prophylaxis, condoms and lubricants, and needle and syringes for those who are injecting. There are a lot of challenges in implementing these interventions, given the entire context with the way people are using, the fact that the substances are illegal, the fact that there are underground networks organizing these parties, but still the interventions that are recommended are, you know, the continuum engagement with club owners and those who are organizing the chemsex party, targeted information campaigns through the apps on which people met, and availability of information, condoms and needle through the community supported routes that, you know, was proven to be more efficient. The next slide, please. The needle and syringe programs for people who use stimulant drugs, you know, it has to be tailored differently than for people who use opioids. The stimulant-friendly needle and syringe programs should have different hours of operation, should be seen as an entry point for a service cascade such as voluntary HIV testing and counseling, and should also provide information on risk reduction and condoms, and also more information about the routes of transmission. And when implementing these services, we recommend that it's important to understand the context of use, the rapid repeated pattern of injecting stimulants, and the need for enough injecting equipment, and also to understand that the stimulant using session can run and continue for several days. And the next slide. These are other paraphernalias recommended in the tool. The needle and syringes, the crack pipes, the meth pipes, the silver foil, the safer snorting kit, and there is clear explanation about how and when this can be used and how should be distributed. The next. We also in the paper we look about the addressing the needs of women who use drugs and how to tailor the interventions so that they will have access to the services as well. And next. Apart from the capacity building program, we also had targeted intervention in the area in the Eastern Europe and Central Asia, where new psychoactive substances are more used. And we did pilot studies in 6 countries: Moldova, Ukraine, Belarus, Kazakhstan, Kyrgyzstan, and Uzbekistan, to understand, the extent and the use. Oops, they turn off my light here, sorry. But I'm gonna finish, I'm gonna end this soon. Okay, let's see if this works. Sorry. And the last slide, if you can, you can change. And these are the results based on that needs assessment. We had a program of web outreach in the countries where we mentioned: Belarus, Moldova, Ukraine, and Uzbekistan. And people were referred to other services after online consultation. Some people were referred to antiretroviral therapy. And, people were encouraged to test for HIV, hepatitis C, and sexual transmitted diseases. And this is my presentation. Thank you.
Thank you very much, Monica. Monica is in South Africa for some training, so she's had a bit of difficulty with the presentation and the lights. But thank you very much for presenting what we have from UNODC side. Now we are very pleased to go to our WHO colleagues, Dr. Anton Mozalevskis and Dimitri Krupchanka will be presenting the WHO guidance on addressing stimulant drug use among people who inject drugs. They have both also had many years of experience on working with key populations, especially addressing people who use drugs. So please, without further ado, Antons, you have the floor. Thank you very much.
Thank you for introduction, Fariba. Can we please move the slides? Yeah, so very briefly about the latest data on the epidemiology of drug use from the World Drug Report. So globally in 2022, there were 292 million people who use drugs, which constitutes 0.56% of the global population. And just for comparison, there were around 44% of the global population consuming alcohol in 2019. So just to give the scale. And only 64 million people were living with drug use disorder, also comparing to 400 million people living with alcohol use disorder, which is 7% of the global population age 15 and older. And as Monica mentioned, it's estimated there are 13.9 million people who are injecting drugs in 2022, and we don't know precisely what proportion are injecting stimulants and what proportion are injecting other drugs. So next slide, please. A bit more data on the burden or on mortality related to drug use from the latest WHO report. So in 2019 was estimated that 583 1,000 people died due to drug-related reasons, and the vast majority of the mortality are, of course, due to opioid drugs, and mostly about due to drug use disorders, but also hepatitis C virus infection. And as concerning to stimulants, together cocaine and amphetamine, including methamphetamine, use was responsible for around 70,000 total deaths. So next slide, please. As Monica already mentioned, so one of the harms or one of the concerns related to drug use is, of course, infectious diseases or communicable diseases. And globally, the latest data show that there were almost 40 million people living with HIV, and among those, there's 9.6 million people who are injecting drugs. Also, hepatitis B is a global problem, much larger scale than HIV, and those, although there is a vaccine available, and there is also long life treatment for those who are eligible. And hepatitis C virus, the latest WHO estimate says that there are around 50 million people living with chronic hepatitis C virus infection. And we also know that people who inject drugs are a much higher risk of incidence and also mortality, and around 1/3 of the global HCV-related deaths were attributed to injecting drug use. And also, it's important to remember that people who use drugs tend to have higher rates of tuberculosis and latent TB infection. Next slide, please. So, as we're speaking about stimulant drug use, Monica also mentioned that apart from injecting risk related to injection, there is also sexual use, and there is a lot of overlap between people who use stimulants and other key populations such as MSM and sex workers, and they have a much higher incidence and prevalence of STIs, including bacterial STIs, but also human papillomavirus infection, and so on. So it's important to take the person-centered approach and comprehensive and address not only HIV, hepatitis, but also STIs. Next slide, please. So WHO has updated its guidelines in 2022 and also included the person or people-centered approach concerning prevention, diagnosis, treatment of HIV, viral hepatitis, and STIs, because these are overlapping epidemics, and people need to, their health needs to be addressed in a comprehensive manner. And the guidelines, they also define the recommended package of prioritized interventions by populations. So next slide, please. So the essential interventions for addressing health of key populations include enabling interventions, and Monica listed very well all the structural barriers that people who use drugs and people who use stimulants are facing. And so the main four areas how to address those structural barriers include removing the laws and policies, including specifically the criminalization of drug use and possession, then interventions to reduce stigma and discrimination, empowerment of the communities, and addressing violence. The next slide. The recommended package of health interventions for people who inject drugs. So in WHO guidelines, there is a generic package for people who inject drugs. Of course, it can be and it should be adapted for services addressing stimulants use, but the basic package remains the same. So it includes interventions for prevention of HIV, hepatitis, and STIs, diagnosis and treatment, And for the prevention, of course, there is a harm reduction package, and in WHO guidelines, it is defined as offering needle and syringe programs, and primarily it's developed for the opioid use, but also since there could be also polydrug use, and services need to be comprehensive. The harm reduction services need to offer the full package of needle and syringe programs, opioid agonist maintenance therapy, and a community distribution of naloxone. But of course, when we're talking about risks related to stimulant use, there are specific interventions which are mentioned in the UNODC, WHO, and UNAIDS guidance, which was greatly presented by Monica. Essential interventions for broader health, but not directly have impact on the incidence and prevalence of HIV and hepatitis, include other interventions. So mostly importantly, interventions for mental health, and also screening and treatment for harmful alcohol and other substance use. So maybe next slide. And also, as Monica mentioned, that stimulant use has a specific pattern in men who have sex with men, which is now known as chemsex, and it's a growing phenomenon. And for the purpose of the guidelines, is defined as when individual engage in sexual activity while taking primarily stimulant drugs, and typically involving multiple partners and prolonged time. And WHO comes with the good practice statements that addressing chemsex among key populations, primarily men who have sex with men, requires comprehensive and non-judgmental and person-centered approach. That includes integrated sexual and reproductive health, mental health services, and access to harm reduction equipment, and also linkages with other evidence-based prevention, diagnosis, and treatment interventions. So the next slide, and I think I will pass over to my colleague Dmitry on specifically interventions for the treatment and drug use disorders. Over.
Thank you very much, Anton, and hello, dear colleagues, and thank you, Fariba and others, for giving us space in this webinar. And as Anton said, that there is a range of guidelines produced by the World Health Organization, and one of them, which is a product of the Department of Mental Health and Substance Use, is the guidelines for treatment and care for mental, neurological, and substance use disorders. So this is one of the key products at our department because it addresses a range of mental health conditions: depression, psychosis, anxiety, and among them, alcohol use disorders and drug use disorders. The guidelines is quite comprehensive, and the beauty of it is you can use different chapters. So if a person has comorbidity like depression, you can apply the depression module for people with drug use disorders. But what I wanted to quickly mention during this webinar, that last year we have done a new round of regular update of these guidelines. We do it like once in about 5 years. And there is a range of new recommendations which are specifically targeting people with stimulant dependence and stimulant use disorders. And some of them, in a bit shorter version, you see on this slide. So there is 5 new recommendations, and so maybe I'll go through them. One of them is about screening and brief interventions for people with psychostimulant use. And it also has another recommendation that if people don't respond to brief intervention, then they should have access to specialist level interventions, like at the specialist level. And then we have recommendations on pharmacological treatment of stimulant use disorders. And this one is negative recommendation. And I hope that in future this will change, because some of you might know that there is ongoing research studying different type of medications to use for this group of people, like as a substitution treatment, like with dexamphetamine, methylphenidate, and modafinil. But at this stage, our guidelines development group decided that the evidence is not sufficient, especially for global recommendation, and also because these guidelines are specifically focused on non-specialized healthcare providers. So you see, there's at the moment they're not recommended for treatment of cocaine or stimulant use disorders due to safety concerns. And so, I mean, I could talk much more on that, but I think we can just stop at this stage. But hopeful about the future, and I should tell that there are a lot of developments. So some countries do have now positive recommendation on pharmacological treatment, but rather only in low income or in high income settings. So then we have quite strong, actually strong recommendation on using psychosocial interventions, and specifically two which are very well studied and showed good effectiveness are cognitive behavioral therapy and contingency management. And actually the effectiveness of contingency management is actually comparable to some of the pharmacological treatment, but unfortunately it's not that widely available. So, but there is recommendation about these two specific psychosocial interventions for people with cocaine and stimulant dependence. And finally, there's one additional recommendations now speaking about recovery-oriented services. But again, it stresses that should be on voluntary basis, and it should be considered. So, I mean, if people don't need it, don't want it, should not be insisted against the will. And we list there a couple of approaches that showed effectiveness, such as case management, long-term residential and community care approaches, occupation-based therapies, and of course, peer support groups. And these are the new recommendations in this update, but there are also old recommendations which remains valid, such as on outreach, on needle and syringe programs. They're still valid in the guidelines. Now we are working on operationalizing these guidelines, meaning developing an intervention guide and protocols for clinicians, and hopefully we'll start active implementation in countries. So thank you for your attention. That's over for me.
Thank you very much, Antons and Dimitri. It was very interesting presentation on the WHO recommendations and also your guidelines and your training packages. So thank you very much for your presentations. I would like to now move to the next session, which is on implementation practices. And we have also two speakers who are going to be talking about the practical experiences from countries that implement strategies and interventions to address stimulant drug use. We have Angela Voits from Mainline, and also Yolan Andrews, who is from NACOSA. And they both have many years of working with the people who use drugs and support in terms of harm reduction. Angela is in Mainline in Netherlands, and Yoland is based in South Africa. So please, Angela, you have the floor because the time is also running. I think we're running a bit late, so please, you have the floor. Thank you, Angela.
Thank you. And I think that Yolan will go first, and then I will come after her, if that's okay. Thank you.
Good day, everyone. I'm just checking. Thank you very much. We can move to the next slide. Just an appreciation for having NACOSA present on this. As everyone would know, NACOSA is a principal recipient for the Global Fund grant in South Africa, and we are the grant managers for this period of 2022 to 2025. The program specifically focuses on opiate users. So our focus is on injectors. We have approximately 15,586 consistent injectors in our program of heroin, but also we have 3,000 opiate smokers involved. The Global Fund program specifically has several spheres which we're quite proud of. And yes, it is quite a clinical program in terms of the standard HIV testing, the provision of harm reduction packs and other sexual commodities, but it also implements methadone program as well as a hepatitis screening, testing, and treatment program in 8 districts, or what you would know as cities. We have psychosocial support, which is crucial, not only in terms of adherence to treatment, but also in terms of, any behavioral change as well as contemplation, life goal changes. And then our human rights program also has been incredibly critical. And we've used our human rights program not only to document human rights violations that have been experienced and responding to that, but also advocating for the expansion of harm reduction services throughout the districts in our country, and particularly advocating for a substitution therapy program for stimulant users, as well as other harm reduction interventions for stimulant users, particularly those at high risk, which are those that are injecting stimulants. We may move on to the next slide. So in terms of the next slide, is just to give you an indication of what are some of the programs and what are some of the interventions, and why particular, NACOSA, even though our program is primarily focused on opiates, why we recognize that it's essential that we also provide interventions or encouragement towards interventions for stimulant users. We have a high number of opiate users who have confirmed through WHO Assist as well as through other engagements that they are polysubstance users, meaning that they are also involved in using stimulants. So our program specifically, we recognize that they use and share a range of items to smoke and often burn their lips and hands. And particularly our concern as well is that we have a 21.8% HIV prevalence that is currently being recorded, in South Africa amongst heroin injectors. And also we have an 83% hepatitis C prevalence amongst our OST, opiate substitution patients that have gone through the hepatitis screening and confirmatory test. So already we understand that there's a high risk of transmission of these diseases to others if we do not look at, commodities and support to those that are polysubstance users specifically. So what we're focused on is reducing health risks from sharing smoking supplies. We're doing community education around the risk of spreading infectious diseases. We're looking at the sole and the dual use of, cocaine and opiates. We are also looking at preventing the spread of TB amongst, and South Africa particularly has a high prevalence of TB, not so much necessarily in the key populations, but around the general populations that there's obviously interaction with. We also recognize that COVID-19 played a real big risk in terms of the spread of that disease through the sharing of smoking apparatus. And what we're also wanting to do is, in response to, autonomy and control over their drug use and health risks, we're trying to provide, commodities such as safe smoking packs, education, and IC materials to reduce that risk. We're also wanting to reduce the risk of, injecting. So recognizing that smokers of stimulants are potentially transitioning to injecting, we want to discourage that start of injecting and reduce how often they inject by, supporting the use of safe smoking packs to minimize that transition, as well as, the possibilities of skin infections such as abscesses, vein damage, and also the risk of overdosing. Lastly, our focus on stimulant use programs or polysubstance use programming is also to expand the engagement opportunities for people who smoke drugs and do not inject. So our focus is, attracting people who use drugs or use stimulants to better understand the need of harm reduction services and how they can incorporate it to avoid, injecting, or if they are injecting stimulants, how to further reduce their risks by refusing to share injecting equipment when using stimulants. We're also looking at how we widen the knowledge and understanding of all those that are interlinked to their substance use, such as mental health, as well as the intersectionality around sex work in the means of responding to their substance use. Next slide, please. So this is just an example. Sorry, we can go to the next slide. I think Karabu, there we go, fantastic. So this is just an example of the harm reduction safe smoking packs that NACOSA has distributed to our 8 districts. These packs are very simple and have been endorsed to a certain extent by South African Network of People Who Use Drugs. The reason why I say to a certain extent is because we recognize that in actual fact, for stimulant use, what we do need is pipes as well as smoking bulbs that usually are used when one does what we refer to as TIC, which is meth. Unfortunately, it is a little bit difficult to source these equipment in South Africa as well as to get them approved. But in the long run, this is the serious consideration that one needs to make. In the meantime, though, what NACOSA has provided is you pipe mouthpieces to reduce in terms of the spread of TB, COVID, as well as HIV from cracked lips. Obviously, we acknowledge that there is smoking, so we have the aluminium foil, the Rizla papers, which is an alternative way of smoking these stimulants, Vaseline, because obviously a large portion of our population are actually unhoused, or what one would refer to as homeless. And so, you know, in terms of ensuring that there are no cracks on their lips that could result in the spread, obviously steel wool, alcohol swabs, and then also just to note, IEC materials is incredibly crucial. So we can move to the next slide, but the next slide will just give an indication once again about why there are particular, you know, items that are used in terms of reducing the risk of certain diseases, as well as other effects such as, sores and cuts on their lips. We may move to the next slide. It is very unfortunate, but perhaps not uncommon in many countries, that the overdose incidence information in the countries is very, very limited. In South Africa, we are fortunate to have the Sekendo reports, and a majority of the reports come as well from rehabilitation centers. But overdose information is very scant, perhaps, in our community implementator programs. What NACOSA had done, which is to look at a very simple form that one could be completed on your phone, with 25 questions related to overdose incidence experience. And we did this within the 8 districts from the 4th of July, 2024 to the 12th of July for a very short period of time. And we managed to find 1,037 respondents, of which 84% were male. Unsurprisingly, 64% of those respondents were actually homeless or unhoused. And what particularly was interesting, but not uncommon, is that 66% of them indicated that they use multiple drugs. So they indicated that they use opiates, but also a large amount of them indicated they use crystal meth, they use mandrax, and also crack cocaine. And so this was important information to understand, excuse me, to understand particularly what is the package of services that needed to be included in our opiate program. 72% indicated that they had never overdosed, but those that did experience an overdose, 96% reported that it was opiate related, and 33% reported having experienced a stimulant drug-related overdose. Of those that experienced an overdose, 84% reported that it was accidental. But concerningly, 30% indicated that their overdosing was intentional. So it gives you a good indication that alongside your clinical programs for opiate and stimulants, you need to consider strengthening and ensuring psychosocial support and mental health services. 55% indicated that they had witnessed or know of someone overdosing, and very concerningly, 72% of those that reported witnessing it or knowing of someone had seen that person have a fatal overdose. So overdoses apparently occurred mostly at night, and a lot of the times it occurred when there was no health services available, like ambulance services. And also 55% indicated that they were unsure or they did not know how to prevent overdosing or manage overdosing of stimulants and opiates. And this highlights a need for increased education and support. So from our side as NACOSA, this was very valuable data to highlight, what is the current situation with overdose management, but also to advocate in our country to have community-led and community distribution of naloxone and a response to overdosing of stimulants. You may move to the next slide. So very shortly, because I've run out of time, is just to acknowledge that NACOSA has been very fortunate to partner with several organizations, and as a result, have been able to assist or focus on what the CHEM6 package of services should include for MSM. And so we are a member of the CHEM6 Guidelines Committee that's supported by the WHO. We have particularly submitted sections on harm reduction considerations for young CHEM6 users, as well as SLAM6 users. We also have focused or provided input around post-violence care support for CHEM6 users, people, MSM that are involved with particular substances. And also we have provided some inputs around overdose management, where we are looking at those being included in the amendments to the South African HIV Clinician Society guidelines for harm reduction services. We have also, through the UNODC and some of the colleagues on this call, received training on sexualized drug use, focusing on CHEM6 training. Particularly Out Wellbeing has been a great partner in terms of educating us around sexualized drug use and assisting us in amending our data capturing tools so that it can inform around sexualized drug use to provide a better understanding of intersectionality and how we respond to it. We also, through the support with Sandput and Out Wellbeing, have developed harm reduction indicators for people who use stimulants that we have submitted to SAKENDU or the Medical Research Council that we hope will be accepted and included for reporting not only from fixed sites, but also community-led sites. And also we have developed particular harm reduction information or IC materials around CHEM6 and stimulant drug use. Next slide. So this is my last slide, and this is just talking about some of the innovations that we've been involved in. And we wouldn't have been able to do this without our partners, our district implementers in those 8 districts in South Africa, the South African Network of People Who Use Drugs, and Out Wellbeing, as well as key technical leaders such as Andrew Schreiber. So what we just want to acknowledge in terms of some of the innovations is that we've worked alongside Sandput to strengthen the contemplation group facilitation materials for people who use drugs, so that it can focus also not only on opiates users, but also stimulant users. We've also funded the virtual opiate substitution therapy ward rounds, which is a virtual platform of learning between local implementers as well as international implementers for particular nurses and doctors, as well as psychosocial staff around engagements of opiate substitution therapy, as well as to exchange experiences and hear about polysubstance use, and particularly the challenges and interventions ones can focus on that. We have also developed a parenting program, the Simbosani program, which was launched in June 2024. And this program specifically was focused on people or parents who use drugs and equipping them with parenting skills and harm reduction, understanding and skills and commodities. And then NACOSA has also worked with Bridges of Hope to develop a facilitator program for psychosocial staff, social workers and counselors, as well as peer educators to facilitate workshops around HIV, hepatitis, as well as the substance users types. This is specifically aimed at young people who use drugs, including stimulant users. And as you can see, we have now also, from the 1st of December, will pilot the distribution of overdose kits that focuses not only on providing naloxone to patients that can be administered by family or treatment support buddies, but also on CPR training, as well as mouth resuscitators to focus on overdose management of those that are using stimulants or overdosing from stimulants. This training is provided to clinicians, but it's also cascaded to the actual clients as well as to their family members or treatment support buddies. We are piloting this in Nelson Mandela Bay, in the Eastern Cape, as well as in Umgungundlovu in the KZN, with approximately 100 service users or patients. And the idea is to do this not only for those that are on
Yolanda, I
opiate
need to
substitution.
start, really, we are really running out of time. If you can wrap up.
Thank you.
Because we
But
have
yeah, this was my last
many,
sentence.
many more speakers. Thank you.
No problem. So we are providing this to our OST patients as well as to non-OST patients that are part of the beneficiaries of the homeless population in those districts. Thank you very much. That was my last slide.
Thank you very much, Yolanda. Thank you very much. The very comprehensive presentation on your work in South Africa. And I think it's very useful for the participants. I would really beg all the next speakers to really stay with time because we are really working over time. So Antela, I would please make it very short. Thank you very much. Please go ahead.
Thank you. Very short, I cannot promise, but I'll do my best. So thank you for having us. My name is Antela Woods from Mainline in the Netherlands. Crack cocaine became the drug of choice for many people in the Netherlands already 20 years ago. So we have quite some domestic experience in harm reduction for stimulant use. But today I want to present on more international work since I think that is much more interesting for the audience here. So next slide, please. We've done some research in 2018 on what works in stimulant harm reduction, and we found 12 evidence-based strategies from different countries in the world. Although it's 2018 that we did this, this is of course, as Monica also said, increasingly relevant because stimulant use since then has only increased in many countries in the world. Next slide, please. So apart from doing literature review in English, Portuguese, and Spanish, we also documented and analyzed 7 different interventions from Canada, from Brazil, Uruguay, Indonesia, South Africa, Spain, and the Netherlands. And then we wrote a guidance report called Speed Limits that focuses not only on HIV and infection diseases prevention, but also on human rights and quality of life for people who use stimulant drugs. Next slide, please. So the first intervention that we found, if you can click once more, yes, oh, maybe one more, sorry, I thought they would come together, is about safer smoking kids. Yolanda has spoken extensively about this, so I will not go into details. With each intervention, I have noted a few examples. The one that is underlined is in our report, so you can also find that. So in this case, Counterfeit in Canada, but also Nacosta has done a lot of work, as you just heard. Then the clicking is going a little bit fast. Prevention of sexual risks is the second one. This was also already mentioned, specifically the chemsex part by Monica, by Antons, and also by Yolanda. And it is also a part of the traditional harm reduction package. At least many of those interventions are. I just want to draw your attention to safety and well-being, and also to addressing violence, abuse, and staying in control in sexual interactions and sexual relationships, which is particularly important. Then the third one is female-focused interventions. So women who use drugs are exposed to additional harms as compared to men. And they need particularly, they need interventions to access healthcare, but also pregnancy and parenting interventions, also mentioned by Yolanda already, and interventions addressing their sexual and reproductive rights and health. So we're also talking, for example, about nutrition care for parenting and pregnant women, but mental health care, childcare, family support, and of course laws that do not take away children of drug-using parents, drug-using mothers specifically. And in this case, it's also important to include the partners of female drug users or female stimulant users. Next slide, please. The fourth intervention that we found are drug consumption rooms. They are supervised healthcare facilities where people can use drugs traditionally focusing on opioid users, but also proven to be useful for people who use stimulants. They increase access to healthcare. They reduce public drug use, and they also promote adhering to other types of treatments. And again, mental health treatment being one of those important ones here. The fifth one is self-regulation. This is important because specifically with stimulants, people, they can just use for days and nights in a row without sleeping, without eating, as opposed to what we usually see with opioid use. So it's very important for people to be trained and to learn how to regulate their drugs. This can be through the contemplation work that, again, Jolande mentioned, also through mindfulness. And in the Netherlands, we have done a lot of work around this with games and advice coming from the community to train people on how to control their drug use. Then the next one is housing first, as opposed to first treating people and having them becoming abstinent. We've seen that helping them finding a safe place to live is much more effective. Specifically, the two examples that are shown here from Atitude and from Braços Abertos, both in Brazil, we saw that people managed to control their stimulant use much better once they had a safe and place to stay. Yeah, housing first, very important. Next one, please. Substitution is one that we know, of course, from the opioid drug use, but also in stimulant drug use. This could be, and this is a important intervention, though there is not enough evidence yet. There are some tests and some pilots done, for example, with dexamphetamine for crack cocaine, and also with bupropion for amphetamines. But I think, well, we think more work is needed and more research is needed here. In the meantime, we see that simply trying to, I don't want to say promote, but to support people in substituting at least part of their stimulants with cannabis also helps to calm down, to work on mental health, and to have better sleep and better nutritionist results. Then the next one is peer-led outreach. I think this is not a new one for anybody. Peer-led outreach is always important, so also for stimulant users. The example here comes from Indonesia, where Charisma has got a lot of good work with Shabu or methamphetamine users. Peer work simply helps to reach people better. It makes your intervention more acceptable, and of course, it also empowers the people whom are most important. Then drop-in centers, also not a new one. Drop-in centers are specifically for stimulant use, very important, again, to offer a safe place, to offer some time for relaxation, for hygiene services, for food also specifically, and again, for taking care of people's mental health. Next slide, please. Then we have drug checking, which is specifically used until now in nightlife settings, where people can hand in part of their drugs for it to be tested voluntarily and without any danger of being caught by the police, obviously. We have seen in our own country that this helps people to take wise decisions on whether or not to take that drugs, if it's not what they're expecting or if it seems to be polluted with unwished agents. So people really do take wise decisions after their drug checking results. Then we have online interventions, which can be self-guided or can include contact with a professional. They are obviously cost-effective, can be accessed at any moment, and it makes it much easier for people to access care if they have access to the internet, of course. There is strong evidence that this works for a variety of mental health issues and for controlling alcohol use. There is a little bit less evidence for drug use, but hopefully that will come if more research is done. And of course, it's always good to do these online interventions combined with other therapeutic interventions, which is the next and the last one. So therapeutic interventions can, of course, include a lot. They can be done by specialists, but also by non-mental health specialists. They can do simple interventions as CBT, contingency management, motivational interviewing, all those kind of things. So there is a lot possible in this. And again, it helps commitment to change. It helps mental health. It helps controlling drug use and reducing drug-related harms. So this was my sprint through the 12 interventions that we found. On the next slide, you can see some general advice on what is important when implementing harm reduction interventions for people who use stimulants. These are also described in the guide, so I would recommend that you download it and you read it. On the next slide, you can see our approach, how we work with partners around the world. So ideally, we can be asked to develop interventions with peers or with harm reduction workers, then train the people who are supposed to implement those interventions, and then also guide the service delivery and make sure that the learning is put into practice. And then the last slide, I think I'm doing well on time, right? I just want to show you the report that I've been talking about and some links to our websites, which is also a stimulant field lab where you can find more of our work in Asia, where we've done big work on stimulant harm reduction, our ChemSec site, and our harm reduction school, where you can find online courses that you can access also on mental health and also on stimulant use. Thank you so much.
Thank you very much, Angela, and thank you, Yolan. It's really amazing work that your organizations and you both are doing in the different countries. It's just amazing how much can be done on harm reduction for stimulant users, although, as you mentioned, Angela, we don't have the evidence for having a substitution program, but there is so much more that can be put in place and to be done at country level to ensure that people are living, using more safely and having a more healthy lifestyle. Thank you very much. So without further ado, we go to the community perspectives, which we have two presenters, Sean Shelley, who is the Executive Director of Harm Reduction International, and also Bikas Gurung from NANPOD. And they will be presenting on the lived experiences and make recommendations related to design and implementing holistic harm reduction interventions. So Sean, thank you very much. I think you're going next. Please, you have the floor. Thank you, Sean.
Okay, great. Thanks very much. Thanks to everybody who preceded me, and it's very useful. I want to stress that what I'm going to say now is as a person who's used stimulant drugs for 28 years, so they're not the opinions of the organizers or of the organizations I represent usually. But I do want to thank people such as Mainline, ART, TB HIV Care, SANPUT, and Input for this journey along treating methamphetamine and other stimulant use disorders. And in particular, my co-author, Matt Southwell, who worked with me on a number of things, and also to the Voice of Reason, which is the A team in South Africa, Julie and Tara and Angela and Charity. So thanks to everybody for your support in this work. Now, methamphetamine is the particular drug I'm talking about because it's the one that's most topical at the moment. It's a really interesting drug. I remember going to the United States with a prescription of methylphenidate for my ADHD, and everybody wanting to swap methamphetamine for my methylphenidate, which I found really interesting because I asked them, well, why don't you just go to a doctor and get it prescribed? And the reason is, number one on the list, do not prescribe for somebody who's had a stimulant use disorder. But in my mind, it's much better rather to take a regulated drug than an unregulated drug. So I found that quite interesting. And this is kind of mimicked, if we can go to the first slide, in a lot of the, can we go to the next slide, please? Yeah, and again. Thank you. You know, we've heard this, the most dangerous drug in America the United States Attorney General in 2005. If you go on to the next one, I think you'll have the New York Times or the Washington Post, who say the most malignant addictive drug known to mankind. And at the same time, in the similar time span, you've got the next slide, please. The head of the US Air Force wing, saying that this is a life-saving insurance policy that saves life. It's common, legal, ethical, moral, and correct application of methamphetamine is what he's talking about there. And if we go to the next slide again, we'll see this contradiction once again with ADHD medications, which are very similar in construction. And then this particular poor gentleman was arrested for supplying Ritalin to school kids and treated as a drug dealer. And yet we've got people prescribing these drugs. So the question is, what makes this particularly dangerous or less dangerous? And in my experience, dose has often been the key factor in what causes the most harm. And out of this realization, we developed contemplation groups and various approaches. So this is what I'm going to give you now, is just some practical advice on how to reduce the harm of people who are already using methamphetamine and who maybe aren't in the place to stop immediately, and there's no other prescribing for them, an agonist prescription for them. So what can we do with it? Right, so if we go to the next slide, we talk about the actual harm reduction, going back to Zinberg's drug set and setting. We've got the drug, the environment, and then the setting, which is your mental health, your concept of the drug, your physical health as well. And each person has vulnerabilities in these different areas. Next slide, please. As I say, this is the drug set and setting. Do you have, you need to consider your risk with the drug in particular. But one thing with methamphetamine is that at a certain dose, it can achieve certain things. Going above a certain dose doesn't achieve anything positive for anybody. So what we did with people using methamphetamine was to ask them to work out at what point they got the benefits and at what point did they start getting the negatives, and then encourage people not to move beyond that original point of where they feel they are getting benefits, but also to consider that. So here's the actual advice we gave to people. If you go to the next slide. And the smaller doses, less frequently. Give yourself a break. Try not to mix your drugs. So in particular, the smaller doses, less frequently, we were saying to people, think about each dose that you've got. Remember that you're wasting money beyond a certain point. You're not getting any benefit whatsoever and more likely to have a psychotic break or to be have the problematic effects of the drug. Try not to mix in particular with cannabis. Cannabis use alongside methamphetamine use has been shown to increase your chances of a psychotic break quite significantly. Use in places where you feel safe, where you are known to be able to use the drug without being interrupted, without feeling that paranoid. Plan, think, and reflect. One of our major goals is actually that people make good, conscious choices about when, where, and how or not to use a drug in each time. So what we do is we say to people, ask yourself, why are you using the drug at this particular moment? Don't necessarily say to them, stop using the drug, just why are you using it? Ask that question 3 times to get down to the bottom reason. And once you start doing that, we see people being more contemplative around their drug use. This is combined with interventions such as mindfulness practices, reality checking with life itself. What is your reality that you're living in? Accepting things like triggers and being tempted to use the drugs and cravings and that. But just think about it each time you use and reflect on why you're doing it. And we found that to be very, very helpful. And of course, eat and sleep. Sleeping is the most important thing. Sleeping causes many of the symptoms that you see within stimulant drug use. The psychotic breaks, we also would say to people that once they resolve that psychotic episode, to work out what the precursors were, to accept that when you hear your voice being called from somewhere in the distance, but there's nobody there, that this is the early signs of you moving towards a psychotic episode. Get some sleep. If you can't sleep, just lie down with the lights off. And don't wait for perfect before you change. That's one of the big misnomers in the field of drugs. You've got to stop using before your life can change. We found that when people start making changes to their life, it's their drug use that changes alongside it, rather than trying to change the drug use without the life changes. I'm not going to go beyond that because we are short of time. Just to say that we had a lot of success with these kinds of interventions, with contemplation groups in particular, and had approximately a 2/3 reduction in admissions for psychotic episodes. And people actually cut down their drug use quite significantly. It was quite irritating because, in one way, because we wanted to do some research on moderated use, but we didn't have enough numbers of moderate use. We had way too many people who stopped using, which is for some people a good thing, for some people interesting. But I hope we can do the research at some time in the future. Thanks very much for your attention, and yeah, good luck with the rest of the session.
Thank you very much, Sean, for sharing your experience, actually. Thank you very much. Can we go to Bikas now? Are you there? I don't see you. I'm not sure if he is where he has joined us. Maybe we go to the next speaker. Thank you. I think Bikas is not there. So we have this session on using the Mentimeter. It's what we should do to ensure that interventions addressing stimulant drugs are included in countries' harm reduction response. I'm not sure how to use the Mentimeter, but so you can scan the QR code below and you can join that. You have the instructions on screen. So please scan it and include your response to what should we do to ensure that interventions addressing stimulant drugs are included in countries' harm reduction response. This would be really beneficial. We can collect your responses and see what new innovative ideas you might bring to the table. So thank you very much. I think we can go on to the next speaker while people are still doing this, because I think we're running a bit late. So our next session is the donor viewpoint. And we have Thomas Brigden from Elton John AIDS Foundation and Susie McLean from Global Fund, who are going to present their point of views. So Thomas, are you there?
Hi, Fariba, can you hear me?
Yes, thank you, Thomas. Please go ahead. Thank you very much.
Okay, great. We can move on to the first slide. Great. Hi, everyone, and thanks again for inviting me to join this important session. I'm going to speed up my presentation just in the interest of time. We can move on to the next slide, please. Thank you. So this is a very brief overview of the foundation and what we fund as it relates to people who use drugs. So we have 3 goal areas. The first is around reducing the criminalization of people who use drugs, and also the criminalization of services. The second is around resource mobilization, making sure we get more funding globally for harm reduction, including interventions for stimulant drug use. But the third area is probably most relevant for today, which is really around seeking to ensure that harm reduction services meet the diverse needs of people who use drugs and do reflect current trends and dynamics globally, as we've seen today. Next slide, please. So we've long supported work for people who inject drugs since the early 90s when we were founded. We've expanded that remit to allow partners that we fund to look at non-injection drug use and non-opioid drugs, including stimulants. We're a private foundation, so we have a degree of flexibility in being able to pivot to support new models or pilots or test out new theories and concepts. We're also looking beyond HIV as the entry point and how to engage people in services through other routes to increase those engagements in programs. So we've heard how services for stimulant use can bring in people who aren't being reached by more opioid-focused harm reduction interventions, which then presents an opportunity to offer additional support. And we're also looking at where themes intersect. So mental health, sexualized substance use is a real growing feature across our work, including in our other portfolios for LGBTQ communities and also for young people. Next slide, please. So onto a bit of the work that we fund. We've heard a lot about South Africa, but it's a really great example of stimulant, a very holistic stimulant program in action. And I should say that all the work that I'm going to present is not done by us. We're not an implementer, we're a funder. So it's really down to the fantastic partners around the world. So we work with an organization, Out LGBT, who are on the call today, to build out this holistic model to increase adherence to ART amongst HIV positive men who have sex with men who are also engaging in chemsex. So really building out a chemsex support model for lower resource settings. I won't spend too much time on this because we've had a little bit more about South Africa, but the project's ongoing at the moment, has enrolled over 120 people to date, with 85% of those reporting using crystal meth and 19% crack cocaine. And early results are showing a really high adherence to ART, with over 90% of those enrolled still active in the program, which started in Q1 this year. And evidence from this project is feeding into national level chemsex guidelines and really helping to inform domestic policy moving forward. Next slide, please. So in the US context, we're working across two projects that are reaching people who use stimulants, both with the aim of increasing access amongst historically underserved and marginalized communities. The first is a public campaign that will be launching next year to increase access to opioid overdose prevention medication and raising awareness and demand in Black communities across 7 focus states. It's going to be driven by a local network of community leaders, influencers, faith leaders, and harm reductionists. So we're seeing an overall reduction in opioid overdose deaths this year. But in historically marginalized communities, those rates are continuing to rise. And this project is going to protect people who have not traditionally been met by those programs, including those who use stimulants who are involved in large numbers of fentanyl-involved overdose deaths. And the second project responds to the lack of funding for safer smoking supplies. And through this, we're building out a replenishable fund for unfundable supplies, such as pipes and smoking kits. And these supplies are reaching often independent, under-resourced organizations across the US, which include Black and Indigenous-led syringe service programs, rural delivery groups, and overall groups disconnected from the traditional public health landscape. Those partners, often very small, are also able to access technical support and fiscal sponsorship. And so far, our partners, rather, have been able to distribute over 30,000 free and discounted pipes as a result of that fund. Next slide. In Kenya, we're working with young people who use stimulants in coastal regions. And again, a real focus here on the intersection of drug use and sexual and mental health. This work is ongoing through an organization called Maywa, supported by Mainline. So we're really looking forward to more data and evidence from this coming out next year. And in Kyrgyzstan, we've just wrapped up a project this year, working with people who use new psychoactive substances. And through that, offering a package of support to reflect, again, regional trends in drug use and building out the evidence base for HIV and new psychoactive substance use. And again, I believe there's more information coming out on that through an evaluation soon. So please do keep an eye out. And last slide, please. Yeah, so as we move into 2025, our partners and the foundation are really going to look at how to share insights and evidence from these programs, hopefully via more communities of practice like this. And we're also developing a new grant-making strategy next year for kickoff in 2026. So it'd be really great to hear from others about gaps, opportunities for stimulant drug use and the intersection with HIV. So thanks very much.
Thank you very much, Thomas. Thank you for all the presentation on the work of the Elton John Foundation and how you're engaged. Please, Susie, thank you very much. You have the floor.
Hello, Fariba. Hello, colleagues. Sudhi McLean here. I'm the Senior Advisor on HIV Prevention at the Global Fund. From what I understand, Fariba, we're over time. Is that right? Yeah, so I don't have slides. I'm sure you'll be relieved to know. I just want to make a few comments from the perspective of the Global Fund in terms of our interest as a donor in this space. Really helpful and very interesting to follow the speakers. Like, for example, great to follow Thomas now to hear from Elton John AIDS Foundation's interest in this area. Great to hear from NACOSA. The Global Fund's a prominent investor for HIV prevention in South Africa, including the work that NACOSA does. All the presentations, I learned a lot and I appreciate it. One of the things that I think I really need to do is emphasize two big things. One, the Global Fund's kind of ongoing and continued interest in HIV prevention investment. So that's why this seminar is super important for us. But I think another thing that it's important for me to do is to speak to some of the constraints, really, because I think it's a really tricky area when we talk about stimulant use and its relationship to HIV transmission. As many of you on the call will know, it's not a straightforward relationship. And the Global Fund, as an HIV funder, HIV prevention funder, we've got something like 5% of the global resource need for HIV prevention. So it's all about prioritization. We really, really try to, in every country, try to find the balance between being flexible and countries defining the programs that they need for the populations that they serve, but also to kind of balance that with a kind of a rigorous attention to the evidence base for high impact interventions. And so, but just to try to get at some of these issues about the HIV, hepatitis, STI risks for people who use stimulant drugs, we changed one of our kind of population categories in our modular framework for Grant Cycle 7, where we refer to people who use drugs as well as people who inject drugs. But I suppose I would be emphasizing that our investment in harm reduction continues to focus on people who inject drugs, because as many of you know, the kind of most compelling HIV transmission issues tend to focus around injecting, or as Anton has mentioned and others have mentioned, in relation to sexual risks related to chemsex. So those are those two areas where we feel like we've got very prominent roles and responsibilities, where HIV transmission risks are most significant, and also too, I would say, as a kind of secondary consideration, where hepatitis and STI risks are relevant as well. So all effort and all need for all stimulant users is a bit beyond scope for Global Fund, but where applicants can demonstrate risks to HIV transmission, we certainly see we have a role to play to be investing there. And just to emphasize that, many of you will already know this, but just to emphasize in HIV prevention terms, our interest continues to be condom programming, PrEP programming, including increasingly, new forms of PrEP and PEP, harm reduction programs, in particular needle and syringe programs and opiate substitution treatment programs, overdose prevention as well, along with HIV test and treat programs and human rights programs. Those HIV funding priorities that I'm sure many of you will know continue to be really important for people who use and inject drugs who are at risk of HIV. So I think I'm just going to hand back to you, Fariba, because we've gone over time. But yeah, I suppose just in summary, Global Fund continues to see a particular role and responsibility for our investment around harm reduction interventions where HIV transmission is demonstrated, or HIV transmission risk is prominent. And thanks for the conversation. It's been great to be here. Back to you, Fariba.
Thank you. Thank you so much, Susie. Thank you for that perspective from the Global Fund. It is very important to have you here, and also, all our donors, because you're sort of making sure that these programs are being supported financially at the country level. And this is what really counts, to expand the coverage and make sure the right interventions are in place at country level to really make a difference. And it's so, this session, I think, with the really wealth of different presentations and the different perspectives, has been really for me, it has been very informative and useful. And I hope that it has been very useful and informative for all the participants. We've had a lot of interest. There are over 100 people who are actually on the webinar now. So I would really like to thank all our host partners, the Global Prevention Coalition, Input, and the South-South HIV Prevention Learning Network. These are such important discussions that really need to be had. And we understood that, we still need we are still a long way away from reaching our targets and goals that we set together for the global AIDS strategy. And we, especially on harm reduction issues, and especially, concerning stimulant drug use, which we don't even have an evidence-based, substitution program to advocate for. But we know that we need to have a comprehensive, non-judgmental, people-centered services for people who use drugs, including stimulant users. And that it is very important to have meaningful partnership and engage with the communities to really understand what works for them and what are the needs. And not forgetting that we also need to talk and advocate with other partners who might not be at the table all the time, but they are very important to make sure we address many barriers that were introduced at the beginning of the session by Monica and by Anton's, the issue of stigma, discrimination, the issue of criminalization. These are barriers caused by people who might not be on this webinar. So we really need to bring them on board so they hear what needs to be done and the perspectives as well. The law enforcement, the National Drug Control authorities, they also need to walk hand in hand with us, us, the health and community, to really make sure that we get to reach the targets that we want to reach. So thank you again. It's been a wonderful discussion. Thank you to all the excellent speakers. And we have another session in the afternoon, which will be chaired by Judy. So thank you very much, and looking forward to more discussions with all of you. Thank you and goodbye.